This panel was recorded Friday, March 19th, 2021, during the 15th Annual Public Administration Research Conference hosted by the Center for Public and Nonprofit Management at UCF. The panel is moderated by Dr. Greg Buckingham. It is titled, Justice, the Courts, and the Other Pandemic, the Drug Problem and Punitive Policies.
All right, well, it is 10:45. And as I like to say, I worked my whole life for NASA, so when it's time to go, it's time to go. So we'll go ahead and start. And I welcome everybody to our panel. We've got a good panel today. The topic is Justice, the Courts, and the Other Pandemic, the drug problem and punitive policies. And we all know that opioids in particular have been a dramatic problem in our society. It's been overshadowed by some of the other things going on, but I know even in my own family, I've been touched by that. And so it's an important issue. It also aligns well with our conference topic about justice and inclusion. And so I think we'll hear a lot about that today also. We have three panelists, and what we'll do is we'll go down and introduce each panelist, and then we'll work our way back with their presentations, and they'll have around 15 to 18 minutes. I'm not that precise, but about that amount of time, and then we'll stop, take a question or so, and then move on to the next. And at the end, we'll have general discussion and other questions. If you do have a question, you can post it in the chat, or you're welcome to use your microphone. And I appreciate everybody, if you're able to keep your video on to do that. It's much more interesting to present to folks than it is to just a name on the screen, but I know not everybody has that capability. Also want to introduce Michelle Pothoven. She is helping me moderate our panel today. She's an undergraduate student who is working with me and an outstanding student. So no further ado, we'll go to Rachel Totaram to introduce yourself and then pass it on to Fatima.
Thank you for that, Dr. Buckingham. Hi, my name is Rachel Totaram. I'm a PhD student at the University of Central Florida. I'm a PhD candidate as of recently, and my research topic really focuses on the intersection of health policy, health research, as well as substance use disorder. So in particular, my research is really focused on opioid use disorder and stigma. Fatima?
Okay, hi everyone. My name is Fatima Ahmed. I'm also a PhD candidate in the Public Affairs program at UCF. My research areas are also in the health service and health policy with a focus on substance use disorder. I have a core interest in vulnerable populations, so that's kind of how I got into substance use disorder. With my dissertation, I kind of went into looking into the criminal justice population specifically with substance use treatment. And so my research projects that I work on, kind of vary, but they're all along the lines of substance use disorder, vulnerable populations, and things like that. So I'm happy to be here today.
Dr. Buckingham, you're muted. In the absence of Dr. Atkins, I can introduce her a little bit, but she is one of our mentors. She works in the Department of Health, or CCIE, and she does a lot of research on women's health as well as substance use disorders as well. She should be joining shortly.
Yeah, I think we all got an email from her. She's coming shortly.
I sent her a quick link. But Rachel, why don't you go ahead and just begin your present. Oh, here she is. We'll give her just a second and we'll roll on with her. I also like to keep my structure together.
She's a grand lady who needs grand instruction.
So I don't get lost.
Hi.
Welcome, Dr. Atkins.
Thank you for your patience.
No problem. So here, I'm Greg Buckingham. I'm the moderator for the panel. Very glad to have you on our panel. And I've already learned that the three of you are sort of cohorts in work. So here's what we've done. Fatima has introduced herself. Rachel has introduced herself. So I'd like you to go ahead and introduce yourself and then go ahead and do your talk. And if you'll pop your chat open, I just set a little timer and I will send you a note to when, as we go along, you have about 5 or 6 minutes left.
10 minutes total, yeah?
10 to 15. We have a little smaller audience, so we probably have a little more time. So.
Okay, great. Hi, I'm Danielle Atkins. I am in the Department of Health Management and Informatics at UCF in CCIE, the College of Community Innovation and Education. I'm an associate professor and I study health policy, and I'm particularly interested in reproductive, maternal, and infant health and substance use disorder in the intersection of those areas. So I'll be talking about one of those projects that intersects today, but I have work in contraceptive policy, and now I've been moving more into substance use disorder policy. And I obviously work with Fatima and Rachel, so I don't know if you would say we are in cahoots with one another. We also are a cohort. So, but yeah, I'm excited to be here today and I look forward to your feedback. This is work that's joint with Christine Durants at the University of Wisconsin-Madison, and she's in the La Follette School of Public Affairs. And we've been working on this research agenda for a number of years. It was triggered by a state policy adopted in 2014 in Tennessee, which is where I'm from, where they criminalized prenatal substance use. So a woman could be charged criminally if she had evidence of substance use during pregnancy. And there were women charged under this law. There was a sundown provision in 2016. It came back up again in 2019, but it did not pass. And so, I didn't want a meeting. Don't come in. Don't come in. It's okay. Just shut the door. Okay. Thank you. It's okay. Okay. Thank you, honey. It's my daughter. Thanks, sweetheart. The joys of Zoom.
Yes. Well, at the end, we'd like to meet her.
Oh yeah, she loves to say hi to everybody. Fatima and Rachel know that well. So today I want to focus on these substance use policies in maternal and infant health outcomes. So although Tennessee had the first criminalized policy, really, there are other states that treated prenatal substance use as child abuse and neglect. So that's what I'm going to talk about today. So why should we care about this? As you all know, we're in the middle of a substance use crisis. Lots of increases in non-fatal and fatal overdose, mostly driven by opioids. So between 1999 and 2017, drug overdose deaths at large increased 250%, driven by opioid overdoses in large part. They increased 400% at that time. So in addition to the direct effects of this opioid crisis and substance use crisis on morbidity and mortality, there are spillover effects for lots of populations, including families and children. And often moms and babies are ignored as part of the opioid crisis. And that's one of the other motivations for this work. So like the opioid crisis and substance use disorder crisis, more generally, prenatal substance use has also been going up. So you can see between 2015 and 2017, there's increases in illicit substances, alcohol, tobacco, and opioids were 6.6 in 2018. In 2019, using data from the Pregnancy Risk Assessment Monitoring System. So this is survey data after mom has delivered. They follow up with her, and over 6% of women, pregnant women, reported using a prescription opioid during pregnancy, which women take opioids during pregnancy, right? But of those women, about 21% reported misuse, which means you took it more than it was prescribed, or you took something that wasn't prescribed to you that was an opioid. And opioid use disorder at delivery between 1999 and 2014 more than quadrupled. So more and more moms were presenting with opioid use disorder when they delivered. And between 99 and 2013, the overall incidence of NAS quadrupled. And NAS is neonatal abstinence syndrome. And it's basically what you think about when you think of an infant who's born with withdrawal symptoms, typically from opioids and other sorts of narcotics. Alcohol use disorder during pregnancy is more difficult to identify at birth. And so there are a host of negative health outcomes associated with OUD during pregnancy and NAS for both the mom and baby. So lots of concerns, societal concerns about prenatal substance use and increases in NAS. So states have taken various responses to that, but there is a mandate by the federal government called the Child Abuse and Neglect Prevention and Treatment Act. That's called CAPTA. And under that, it's been reauthorized multiple times. But the most recent iteration, states are required to, mandated reporters are required to notify Child Protective Services. It's different than a report. It's a notification so that states can track NAS over time. And then they're also supposed to have a plan of safe care for a mom who delivers a baby who's substance exposed, which typically could be setting them up with supportive services and things like that, treatment. There's been research on this and the policy diffusion literature, and there are very few states that are in compliance with CAPTA. So underneath the federal government, states have taken various approaches to prenatal substance use. It started really with the crack cocaine epidemic in the 80s. So many states equate prenatal substance use to child abuse or neglect. So that can be grounds for removal of the child and ultimately termination of parental rights. And that's the policy that we're really interested in studying. So instead of maybe triggering an investigation, right, in these states, a substance exposed newborn, that is equivalent to child abuse and neglect. And then there are other policies that states have adopted, including reporting, requiring reporting from mandated reporters like physicians, and testing requirements, and others have adopted priority access to treatment for pregnant women. There are limitations with that though, because not, as you know, substance use disorder treatment is not readily available in general, particularly so for pregnant women. So there's this tension between public health and punitive approaches. So those in favor of punitive approaches like these laws equating prenatal substance use with child abuse and neglect would argue it reduces drug use, it would incentivize treatment, improve outcomes for moms and babies. So that's a research question, right? And then those against punitive questions say it could harm the provider-patient relationship. Mom might avoid prenatal care for fear of child welfare involvement, continued substance use and cycling. So the gold standard of treatment for pregnant women with opioid use disorder are medications for opioid use disorder, like methadone. You can also have withdrawal. Detox during pregnancy, but the use of medications for opioid disorder stops this trying to detox and then relapsing and detoxing and relapsing, which is stressful on the fetus. And then it's complex for pregnant women, thinking about substance use disorder as a disease. And as I mentioned, it's hard to get to treatment for pregnant women with opioid use disorder or substance use disorder more broadly. This is just a snapshot of the states that have these policies that equate prenatal drug abuse to child abuse and neglect. Many of these passed pre-2001, which are before our data period, but this is just an example where you can see how it's kind of smattered over the states, across the states. Okay, so there's some related research. A working paper by Christine Coyer found that early prenatal substance use policies resulted in worse birth outcomes. There's a paper by Faherty and others, and they find that these policies increase rates of NAS just let the cat out of the bag. We find they don't affect them. The coefficient's positive, but it's not significant. So it's somewhat consistent. They define things a little bit differently. They do things a little bit differently. And then I mentioned that there's variation in state compliance with the CAPTA mandate. So we use these policy variables that I've discussed. 20 states adopted them and 7 turned on during our data period. We use outcomes variables on rates of NAS from the Healthcare Utilization Project, and that captures discharges from community hospitals. And we get maternal opioid use from that as well. And then the treatment entry variables, we use the treatment episode data set, and that captures admissions to specialty substance use facilities in the US, and they indicate if a person is pregnant at admission. So this is our graph of our HCUP data for our 2 outcomes with respect to substance exposed newborns that we try to capture. So you can see that neonatal abstinence syndrome is going up quite a bit over our data period. Maternal narcotic exposure, not as much, but this would likely capture more births than this. So we use a difference in difference approach, where basically you take states that are treated, that adopt a policy, and compare the data before the adoption and after the adoption in that state. And then you also compare it to states that didn't adopt. So they're like your control groups. So hence the difference in difference, the pre-post difference and the control versus treated difference. So we use OLS because we log the outcome variables that are rates. And we use year and state fixed effects, which is standard in diff and diff. And we control for other policies like the reporting testing policies, priority access, and prescription drug monitoring programs. So these are the outcomes for the NAS rate here, maternal narcotic exposure here. The big takeaway, none of these are significant. They're positive, not significant, and that persists as we add prenatal substance use policies, state level covariates, and PDMP policies. And then the next set of results shows the treatment admissions. And so what we look at here is the proportion of reproductive age admissions reporting pregnancy at the time of admission. So of reproductive age women, what share are reporting pregnancy when they admit? And we find that this share decreases in states that have adopted these policies. So less pregnant women, there's a smaller share of pregnant women entering treatment in states with these punitive policies. And then we also wanted to kind of try to test this idea that maybe it's through avoidance of medical care. And so the TEDS has information on referral source. And so we look at the proportion of pregnant women referred to treatment by a medical provider. Not significant until the last, model. This is our preferred specification, negative. So this might be suggestive of something like this, but we're not going to hang our hat on that. Okay, so we find no effect on NAS or narcotic exposure at delivery. Treatment admissions appear to decrease. And then there's this tension, right, between punitive versus public health approaches. And substance use is complex. So specifically respect to the policies, many of these policies don't include provisions for the complex nature of substance use. So whether the withdrawal NAS comes from use of medication-assisted treatment or medications for opioid use disorder, whether it's prescribed or not, those aren't captured in the policy. And additionally, they assume that treatment's available often, and it's not. So you can see here, this is in Tennessee for the criminalization law, and women are told in that law you can avoid incarceration if you go to treatment, but they don't have enough treatment beds, treatment availability for women. So overall, if you implement these punitive policies without recognizing limitations in access to treatment, without recognizing the complex nature of prenatal substance use, then they're probably not going to improve the lives of moms and infants and families. So looking ahead, we would hope that states would consider more preventative policies and supportive policies of moms and babies, reproductive age women. Thank you.
Okay. Any questions at this point for Dr. Atkins?
I have one for Dr. Atkins. I wanted to just ask you to explain PDMP and its relevance. I'm unfamiliar with the term.
Yeah, so a prescription drug monitoring program is it's basically a database of controlled substances prescribing for a person in a state. And some states have operational PDMPs where a prescriber can opt in to looking at it and seeing what a person's prescribing history looks like. And other places mandate that prescribers do that. I believe Florida mandates it. And it's meant to curb doctor shopping, where people go around to different prescribers and get multiple controlled substances prescriptions. And it's also meant to prevent, not intentional, right? Prescribing of potentially dangerous combinations of substances.
Thank you.
I had a couple, just one question. I know in other debates, public policy debates, the welfare of the baby is highlighted as paramount. And I wondered in the punitive, for the group that talks about the punitive model, is there discussion of what's best for the baby, or is it all about the mother and the punishment for her behavior?
That's interesting. I think that the discussion around it is it's all about the babies, really, right? Like that's the goal. Help the babies, protect the babies, and we do that because mom is engaging in this, bad behavior, and that's part of not recognizing substance use disorder as a disease. A lot of people have argued that this is a back door into reproductive rights too, like with the fetal assault law, and it's kind of a slippery slope from there, particularly from Tennessee's standpoint. But yeah, I mean, the idea is that it helps babies, but there's no research, right, on that. And that's why we did this, because it's like, well, if that's the idea, let's see if it does. And we didn't find that it did. And other folks have found that it actually made NAS rates higher.
And the treatment, at least in the one case, is not really available, even if it's required.
Yeah, exactly. It just ignores that. But it's easy, I think, to see how people could get behind it, to say, well, if a mom was giving a baby alcohol, she would get in trouble, right? And so mom is giving baby alcohol while she's, during gestation. And so I think that is a clear kind of link for folks to get behind. But again, it ignores all of the complexities. It's messy, right? It's not that simple. It's not that clean.
The other observation I had, Dr. Atkins, and it's just an observation, when you showed that map of the states that have implemented the punitive model, perhaps my bias, but I would have guessed that the southern states were the lead on that. And so I was very interested in the Midwest, 5 or 6 states in the Midwest that have implemented that. And I just, I don't know what to say about that. It just struck me as an observation.
That's a really good point. So those states that changed during our period include, so these later adopters, Iowa, Oklahoma, Colorado, and then others are more from the crack cocaine epidemic. But it's important, and I forgot to say this, in Alabama, it's criminalized. We excluded Alabama and South Carolina because they have court cases that women have been prosecuted. A DA has brought a case to prosecute under not this kind of law, but in a criminalized fashion in Alabama and South Carolina. So that pretty much covers it, except for Georgia, if you add those two. So,
All right, thank you.
Good question. Thank you.
All right, Zoe, did you have a question?
Yeah, I just had a quick question. So thinking about your research and what your findings are, what kind of recommendations can you take from that for public practitioners? And what do you think the likelihood of them actually implementing like what they perceive as like soft policies towards these women would be compared to like the more hardlined approach of criminalization?
Yeah, that's a really good question. I think it is one of those really complex policy areas, what you might call, I mean, the problem is so tangled, right, with all of these different things. So it's really going to take a comprehensive approach. And I'm not sure how, I'm not even sure how these are implemented, right? And that's always an interesting policy question, is how are these implemented on the ground level? And honestly, I think that we have to know that first. How are physicians making decisions? Are they reporting, right? I mean, because that's a necessary condition for this to even happen. And I think that there's the medical practitioners and the decisions that they make, knowing that these policies exist. And then there's that public policy approach. I think we're moving more toward a public health model with substance use disorder in general. And hopefully that will trickle down to pregnant women. But I think this is rife for implementation research, especially for CAPTA with that federal requirement. I mean, moms and babies are meant to have a plan of safe care after they leave the hospital. And some research has found that's not, at least in statute and regulation, actually happening. So yeah, a really good question. Thank you.
All right, I think we'll move on to our second presenter. And again, we'll have time for more discussion at the end. And so we'll go to Fatima Ahmed and hear her presentation.
Can you guys see it?
Yes,
Yep.
looks good.
Okay, so good morning, everyone. Thank you for being here. Today, I will be discussing barriers and facilitators of implementation of evidence-based practices in 5 family dependency drug courts. Before I begin, I'd like to acknowledge my fellow research team, half of which is here today, Dr. Atkins and Rachel, as well as Drs. Andraka Christou and Aussie, as well as the Florida Supreme Court Office of Court States Administrator, who funded this project. So just to give you an overview for this presentation, I'll give you a brief introduction on substance use and the court system, and then talk about our study's objective and the frameworks that we use. And then I'll go into our methodology and some of our results. And then I'll end with discussing what the next steps are in our project, as this still is an ongoing study that we're doing. So currently, as Dr. Atkins mentioned, the US is experiencing a substance use disorder. 60% of people in 2018 reported using some type of substance that can include tobacco, alcohol, or an illicit drug in the past 30 days. And then we were hit with COVID last year. So that was colliding with an ongoing substance use crisis. So this means that there's a potential for even worsening outcomes for people with substance use disorder. And one of those outcomes includes criminal activity. And in this case, sometimes individuals can be referred to drug courts instead of being sentenced to jail. And in Florida, there are family dependency drug courts, or FDDCs, which are civil family problem-solving courts. They aim to reunite parents when their children have been taken away because the parents were found to use drugs. FDDCs can use various approaches to enable reunification of parents and children. The courts that we examined in our studies used various types of interventions for both their clients and their staff. And this can include anything from referral to substance use treatment, such as medication assisted treatment, as well as parenting and life skill classes for the parents, giving them a peer recovery support specialist who is someone who has gone through the drug court themselves and successfully completed a program to help guide them through, someone who's currently going through the program themselves, as well as various staff trainings, such as motivational interviewing skills and other evidence-based training programs. So in our study, we wanted to examine the implementation of these evidence-based practices in 5 counties in Florida and determine what barriers and facilitators there were in the process of implementing these practices. In order to evaluate each court, we used 2 frameworks. The first is the EPIS framework, which stands for Exploration, Preparation, Implementation, and Sustainment. And the second framework was developed by Proctor and colleagues for outcomes of implementation. This includes measures such as acceptability, adoption, appropriateness, feasibility, fidelity, implementation costs, penetration, and sustainment. So our methodology was a mixed methods approach. So this means that we collected both qualitative and quantitative data. And it's important to note that our project is split into 4 phases, and we're currently in phase 2, but in each phase we collect both types of data. So to start with the quantitative data, we created a survey for both the clients and the court staff. Their Likert scale questions, which we can then analyze using descriptive statistics. And if the sample sizes are large enough, we can run inferential statistics. Then for the qualitative data, we conducted focus groups with each court team, as well as individual interviews with key stakeholders that were involved in the implementation process. And for the purposes of this presentation, I'm going to be focusing on the qualitative results that we found, because that's really where we discovered many of the barriers and facilitators to the implementation process. But to quickly finish showing the methodology that we used, once we have both the data analysis done, because this is a convergent design, we would then compare the results and merge them at the end to see if we can make any integrated conclusion at the end. So as I mentioned earlier, this project is still ongoing, and we currently only have finished analyzing the phase 1 data. And we found some facilitators of implementing these evidence-based interventions in the courts to include team culture and communication. So that means having regular team meetings in the court staff and everyone supporting and understanding the value of the selected intervention was important in the implementation process. Also, the use of a familiar and trusted treatment provider for the intervention they selected was often mentioned, because many of the courts mentioned that it's difficult for them to find treatment providers or third-party contacts that they can rely on and trust. So once they establish these relationships, they really try and stay loyal and want to work with them. So if we move on to barriers, we noticed that a lot of discussion on transportation being a big concern for the court participants. So this impacts the engagement of the clients with not only the court, but also with their treatment program and treatment plan. So this was really interesting because we found this across the courts to be an issue. And we also found discussion of staff turnover, particularly with counseling staff, as well as recruitment of peer recovery support staff to be a difficulty for them. And these positions are really vital to the success of clients completing their programs. So the fact that it's difficult to fill and retain, it's really concerning for the court staff. And for phase 1, we were also able to get some COVID-specific barriers from early in the pandemic. So those included the fact that everything was transitioning to remote and virtual. It didn't include the fact that they could not do drug testing remotely and virtually. So that was a large barrier for them because they just had to end those services because of COVID. And secondly, it was difficult to communicate with participants because if they didn't have appropriate technology, then there was just no meeting with them physically at that point. And while we're still in the early phases of analysis for phase 2, I did want to share some preliminary results from phase 2. We collected this in early 2021, so most of these relate to COVID and the impact that it's had on the implementation of their selected interventions. So we can see that transportation is not a problem now because everything has been transitioning to remote and virtual. So engagement has increased because of all of the remote and virtual interactions. However, there have been a lot of talk that overall COVID has resulted in many courts seeing recruitment and retention of participants decline overall in their courts. And this really impacts whether the courts can begin their interventions that they had selected like during phase 1, because if they don't have enough participants, then they can't implement it. And consequently, in some cases, courts are just waiting until they have more clients so that they can get to use some of the grant funding to use and start their interventions. It also, interestingly, we heard that some court staff, while they mentioned that remote services had been great for engagement, it had also been difficult. In some ways, technology is still a barrier, so contacting clients was still difficult. And also some individuals mentioned that there was a reduced level of professionalism now that clients were virtually being contacted, since they were no longer physically coming to a court setting. And so they kind of viewed that as unfavorable, and they preferred kind of having that professional attitude that court participants would have once they walked into a physical court building. So what's next in our study? As I mentioned, we're still in the process of analyzing our phase 2 data, and we will then need to integrate our qualitative and quantitative results to make this a true mixed method study. Additionally, we have 2 more phases of the implementation process to collect data and analyze. So there's still much left to learn from this study regarding barriers and facilitators of implementing evidence-based interventions. And even specifically with the impact of COVID on drug courts, we have a lot that we can still learn through the next 2 phases as the longer impacts it may have on the court system. But that's all I have for you all today. So thank you.
Okay, very nicely laid out. Any questions or comments, observations? Well, I will ask something about your methodology, and I'm probably not going to say it right, but I love the mixed mode methodology. I think that's a very strong approach. Do you do those, the qualitative and the quantitative simultaneously, or does one inform the other as you go through?
Because ours is a convergent one, they're not affected by the other, they're simultaneous. So they're very much independent of each other, and then we merge them at the end and compare the results.
Okay, great. Thank you.
I have a question. If that,
Yes.
yeah, okay. So these results are hot off the presses, so hot off the presses that I hadn't seen them. This is the first time I'm seeing this as well, so it's like I haven't, so that's good. Okay, so it struck me when you said the thing about professionalism. It's just interesting. COVID is lots of silver linings with respect to policy and access to healthcare and all kinds of stuff, right? And I've often thought, because my kids do in school at home, that wow, her teacher can see in our house, right? So now the courts can see in the clients' homes, and they wouldn't have, I don't know that they would have had that opportunity before. So that's just interesting, and I'd like to eventually learn more about that. But my other question with respect to the barriers, so there's this big concern in reunifying kids with parents in general, right? Because of COVID, visitations were disrupted, right? And the big criteria, for my understanding of reunification, is the parent-child relationship. And so when you can't have visitation, that's obviously going to be negatively affected. Did any of the courts mention that?
Yeah, if I remember correctly, and Rachel, you can step in if you remember anything else, there was a particular interview that we listened to where that was like the entire conversation was about the effect on the parent-child bonding, and one case where the individual, like the case was severely impacted because of COVID, like the bonding aspect, because she wasn't able to see her, and you know, she got into trouble and whatnot, and she got back into jail and all this stuff. So like it was just, it did not help the situation, and that bonding element is part of what they evaluate in order to, you know, help decide whether they're going to reunify. So it is a problem, but I think they have said that they're slowly, you know, they've been slowly trying to allow visits and all that, but it is an interesting thing that we need to look into more about the impact of COVID on the parent-child relationship.
Okay. Interesting you mentioned your first point, Dr. Atkins, about a loss of privacy. I just read part of an article in the last couple of days, I think from the Atlantic, on the loss of privacy during COVID. Because we Zoom and because people are at home, they've posted more, they've put more out there. And so there's a concern about the increased loss of privacy.
I agree with, I mean, when your office is your home and your home is your office and it's school and everybody's there together, I mean, there are just no boundaries.
Yeah.
And when you think about this kind of situation, and even with telehealth for mental health, I think it can go either way. Because if it's something that's super stigmatized, then maybe it's good that I'm at home and I can call in. But in other ways, it lays everything, you know, kind of bare.
Yeah.
So I've thought about that with respect to child maltreatment more generally. And especially in states that didn't have an option to go back to school like us, where all the kids are at home and the teachers are seeing into school or into home. You know, I wonder what, I have a question about child maltreatment rates, right? In that capacity and that kind of variation. So I think it's really fascinating. And, you know, I'm of course, COVID is terrible, but the timing of COVID during this evaluation has provided this opportunity, you know, to understand that kind of dynamic, which I think is really cool.
Very interesting.
This is kind of, sorry to interrupt, this is kind of a question that's kind of unrelated, but it could be related, I'm not entirely sure. So in the UK where I'm from, when they closed the schools, vulnerable children that were flagged by social services or any of the health practitioners as being vulnerable were still required to go into schools, so teachers and other health practitioners were able to keep track of them. Is any sort of thing like that available here? And do you think that would help in this situation that we've been talking, if would help allow children to stay with families that were flagged as vulnerable because they were given some reprieve? If the mother has mental health issues, then she would have that 6-hour gap where the kids were still allowed to be in school.
I'm muted. I'm not aware of any, and it's one of the things that we had talked about initially when all these decisions were being made about school, that there are some kids who need a school, right? Not for food and for safety reasons. And that was one of the things that had kind of been batted around, was identifying really vulnerable children. And I think it's less of a concern, perhaps, you know, I'm in Seminole County where you have the option to send your kid back to school, but other places you don't. Like my friend in Wisconsin, that they're just now having the option to send their kids back part-time. And what does that mean for the job market? But you also can look at data and see that women have, the Kaiser Family Foundation has a survey, and women have been more negatively impacted by COVID than men. And I think the hypothesis is that it has to do with what you just said, that there's not that 6-hour window, you know?
Yeah, I think whereas the 2008, 2009 recession was labeled as a men's recession, this is labeled as a women's recession because they have been hurt far more during this. So good point. Thank you, Zoe. All right, let's hear from our third presenter, Rachel. We'll look forward to what you have to say.
Wonderful. Can you guys all see my screen?
Just
Okay.
fine.
All right. All right. So good morning, everyone. Excellent job on the previous two presentations. My name is Rachel Totaram, and I am a PhD candidate at the University of Central Florida, if I haven't already introduced myself to you. Today, I'm speaking on the development of educational videos for court staff and judges, and this is regarding medication-assisted treatment. Today, I'm going to be speaking a lot about what our research team has determined from conducting focus groups and surveys, specifically asking court staff about their preferences on video content, topics, and style. So first, I'd like to acknowledge the primary investigators on this project. That's going to be Dr. Basha Andraka Christou and Dr. Yara Asi. In addition, funding for this study was provided by the Florida Supreme Court of the Office of the State Courts Administrators. This is going to be my agenda going forward for today. And we're first going to start off with the significance and the importance of medication-assisted treatment and its relation to the court system. So, medication-assisted treatment is considered the gold. Medication-assisted treatment is considered the gold standard in treating opioid use disorder. There are 3 primary medications used. These are methadone, buprenorphine, and naltrexone. And there is a plethora. There are just papers on papers pointing to their efficacy and how effective they are at curbing relapses and reducing opioid overdose deaths. However, there are still misconceptions and there is still stigma present, not only in general society, but also specifically in the court system regarding these medications. Now, the question then is, how does this manifest itself? How do we see these misconceptions and stigma play out? Well, there are 2 main areas where it plays out with judges and court staff, and one of them is that they prevent these individuals will prevent clients from being referred to MAT, or they outright prohibit the medication's use in the court system. So what the purpose for the study was to collect data regarding video content, and we wanted to determine what exactly should go into the online learning videos to be provided to the court staff and judges. So these videos would be enumerating on the efficiency of medication-assisted treatment, and also to address some of the misconceptions that court staff and judges may have. Now, regarding these misconceptions, these could have been long-standing throughout the courts, or this could have been from their personal experience. One thing to remember in the court system is that individuals typically sometimes are cycled throughout the system, so they become sometimes familiar faces to these individuals. Videos were provided to all Florida courts and their related parties. So related parties would also include treatment providers and stakeholders through a website that you yourselves can access if you'd like to. It's www.courtslearn.com. Okay, so there were 4 phases of data collection and analysis with each stage, followed by material development by a technology company known as EnfoGlobe. So in this first phase, just with the first bubble, the focus groups were conducted with court staff as well as judges. And what the discussions really centered on was what was important to be discussed in these videos. What would the style be in these videos? What would then happen is the research team analyzed these transcribed audio, looking for thematic themes that would arise continuously, and from there they were iteratively categorized and labeled. These themes were then provided to EnfoGlobe, who then developed an animation going forward. And this is going to be a common theme. Typically, the research team reaches out to the court staff and judges, receives their feedback, transcribes it, and then provides it onto EnfoGlobe. So you may hear me repeating that as I continue on. So then after the animation script was completed, it was then passed from EnfoGlobe to the research team, back to the court staff. We then used a thematic analysis approach. The feedback went back to EnfoGlobe after transcribing it in a program called Deduce. Then they took that and created storyboards. Now, storyboards means the images, the feel, the colors, the textures, everything that was used to provide images for these individuals to later go back and look at during the video period. So imagine if you were a court staff or a judge, what we would essentially be providing you with is a picture, a moving picture of perhaps a client or a judge, and to see what they would look like. So with these storyboards for the videos that were created by EnfoGlobe, we went back to the court staff and asked them whether they liked or disliked elements of the storyboard. Like I said, these elements could be the colors, they could be the drawing, the animation style, etc. So we also had 7 open-ended questions on the survey that they were able to provide if they wanted to. We analyzed the survey data using descriptive statistics, and we conducted thematic analysis of their open-ended survey data. Lastly, the results were once again provided, who used to the company EnfoGlobe, who then used this information to revise the storyboards. So for example, if we mentioned that we didn't really like crisp or clean edges on the images, EnfoGlobe would then take that and rework the images for us and then provide back to our team. So again, with this last stage, we provided it to the judges, we collected their feedback, and then the judges and court staff were willing to give us feedback once again for the last time. In the last stage, we really asked the judges and the court staff about their demographics and what exactly their positions entailed, just asking exactly where they were in the courts. And then lastly, most important to note, these individuals who were participating were in a convenience sample. Okay, so for the results, they're going to be broken up into 2 sections. There's one for video topics and then 2 for video style. So the goal with asking questions regarding the topics and the styles and the different phases was to really determine what should be in these videos. We knew that there should be something relating to how MAT works in the brain. We knew that it should be something about addressing misconceptions, but we weren't really sure about the scope of what else should be in there. So one of the common points was that there needed to be a 3rd video, just starting like straight from the beginning, essentially, like precursing any of the other 2 that we had created, starting with what exactly is an opioid use disorder. And this was to be an introductory video to the court system and the judges. So what this would be is a way to ground the individuals watching the watching the videos in what exactly it is, and from there to understand what the misconceptions are and then who it affects. So in this introductory video, judges and court staff were shown to see opioid use disorder as a chronic condition that could be comparable or similar to diabetes, for example, rather than a moral condition or a moral issue. Another video topic that arose really dealt with the role that courts needed to play with regards to medication-assisted treatment. And something that's important to note is historically, judges and court staff have outright prohibited medications, and this is a violation of the Americans with Disabilities Act. And also, it's problematic for judges and court staff who are not specifically trained or completely understanding the role that these medications play in the body and exactly their efficacy and their use, like a medical doctor would. And the individual could think that they have sufficient knowledge, but the truth of the matter is there's a lot more out there that I think medicine plays a greater role in, right? Having the medical knowledge. So judges and court staff could understand that, but they also wanted to know, well, okay, if we can't prohibit it, what can we do? What exactly is our role? So ultimately, what we clarified after going back and speaking to the office of the talking to OSCA, Office of the State Courts Administrator, was we told them that the court's purpose was for information sharing and for client monitoring. And so what that really involves is a relationship with the treatment provider, that the client is going to be engaged, and the court's role is there to provide sanctions if, let's say, the client isn't passing their urine drug screening and monitoring. But their role isn't to prohibit or prevent them from accessing a medication. That's an entirely different issue if they're not allowing it to begin with. Judges and court staff really wanted it reinforced that MAT is the gold standard of care and that it's effective, and that they wanted to address misconceptions such as that it is just another drug. And there were several parts of the video about that. One of the most important misconceptions that needed to be discussed was the length of time that an individual could be on MAT. We made sure to have a section saying that it actually is better and leads to better outcomes, that an individual should stay on MAT as long as possible, and that there are dangers to abruptly or rapidly discontinuing MAT. An important thing to note too is that a treatment provider could say one thing regarding length of treatment on MAT, so they could encourage it, but being in the court system and hearing pressure from a judge and court staff could have a negative impact, which could sway clients into abruptly ending their MAT use. The last topic really concerns how information should be presented to a viewer. Participants really wanted interviews with someone who had been a client or someone who was a judge that allowed for MAT in the courtroom, perhaps either changed their mind or someone who had really gone through it, that could speak to the fact that it was helpful, and it is truly helpful to the person in the courtroom, and that makes it was a bolster, if you will, to the scientific message that was being delivered, and it provided a personal story that really connected with individuals in a way that previously hadn't, that may not have gotten across as clearly with the scientific evidence. Lastly, court staff and judges really wanted evidence, right? We can hear claims, but they really wanted evidence showing that they can back up what the video is saying. So even though that longer treatment works, right, like as I stated before, it's so widely misunderstood in the court systems that documents needed to be available. So in the e-learning videos, whenever a resource or whenever something scientific would pop up, a link would also appear in the bottom right with a resource indicator, so that they could find and link that scientific article and find it and read it on their own. So regarding style and information delivery, there were a lot of different themes that were provided. Some could look like cartoons, some could look like anime, and some could actually look realistic. But the main theme that was received as feedback was that the style of the presentation, it needed to be professional, it needed to be simple, but it needed to be realistic. So, for example, staff and judges did not want to see an incredibly realistic depiction of the brain showing different parts of it and cutting into it, because in their mind they're like, we're not scientists, but at the same time they didn't want it to be cartoony and not professional looking. In addition, another element that was really consistent was that the court staff and judges did not want to be spoken down to. They wanted to be treated as though they had years of experience or they had degrees behind their name. So we needed to talk to them as though they are still learned professionals, even if there are some misconceptions abound regarding MOUD. and if we think about who actually is in these courtrooms, most of these individuals will have a graduate degree, and that would impact the way that we wanted to phrase things. And we didn't, at the end of the day, we didn't want court staff to feel patronized, right? Lastly, with respect to the animated characters, because there were guide characters in the presentation or in the storyboards and animations, these guide characters would kind of walk the person watching throughout what was going on. They wanted to have diversity. So you wanted a range of genders, ethnicities, races, and everything for all rules. And that's for judges, providers, and court clients. Okay, so regarding the modules, one thing that's important to note is if you go onto this website and take a look, there's actually quizzes and there's actually activities interspersed along with it. So what they wanted to know, what we think and what we're interested in finding out is that e-learning modules could lead to higher degrees of support and interest in MAT after exposure to them, and that's what we think is going to happen essentially. But one thing that we are tasked with in the future is determining exactly how much and who is using these e-learning modules on this website, and also looking at the pre and post quizzes. So we want to see exactly how much their scores have changed. The questions are the exact same before and after. And this is something that we really need to be thoughtful on. But the biggest question that I personally have is, did this change their policies? After they were exposed to these educational videos and these learning opportunities, did their policies change as a result? And I just want to thank you for your time this morning. And if you have any questions or feedback on today's presentation, please feel free to email me, and my email is below. Thank you.
All right, very nice. Questions or observations on Rachel's presentation? Well, I will certainly add, I like that the approach of asking people about the content and the style. I think that's important in order for it to be receptive to the audience, to have not just good content, but the right style. And so I would be very interested in hearing more on how that transpires as you go forward.
Thank you.
Any other comments, questions?
I have a question. So very interesting presentation. It's totally something that I didn't know was a research topic until I met you and Basha. And so it's really important, and it's kind of got this community engaged research flavor, right? Where you're going to the final user and asking them to define the problem, which is so important and something that I've just recently learned about. And you're also getting to see it from the beginning to the implementation. I mean, all the way through the whole process, which is very, very cool. And I may have missed this, but is there an evaluation component
on whether they
on the intervention in general? I mean, I know you're getting the feedback and developing the module, but is there an evaluation piece about the effectiveness of the trainings?
So I know that OSCA has, and OSCA is just the acronym for the Office of the State Courts of Administration. OSCA has reached out to our research team and conducting a follow-up about a year out. So we are interested in finding out, regarding the impact of these e-learnings and whether their policies have changed as a result. So this is something that will be coming up in the future. As it stands currently, because this has been, I want to say that the website has only been up for approximately 2.5 to 3 months. Right. So I don't know if that's necessarily enough time. I'm sure it is, but I think that we are waiting until something more, a little bit more time has passed, and perhaps with a little bit more changes with COVID before we continue on and before we start that.
Okay, follow up are there evaluations inside the?
Oh, yes. Inside of the modules, there are pre and post quizzes. So before it, let's say the first one is what is an OUD, right? An individual will be asked multiple choice questions like, what do you consider an MOUD? And then listed as either a moral condition, this is something an individual has an issue with an addiction, or this is a chronic health condition. And the same questions are present before the module and after the module. In the middle of the module, there are also activities such as matching, etc.
Okay. So it is this kind of like educational intervention.
Yes, yes.
Do they know their scores before and after?
I believe that they do. They are given something, but I'm not sure it's enumerated like the way that survey data or like Qualtrics would pop those numbers out, if you know what I mean. It would just show like, oh, this is how much the knowledge gap has increased or decreased.
Okay. I'm thinking of the trainings that I've done through UCF, right? It's like,
yeah. I think something important to note too, and not to cut you off, but I think there is a real incentive for these individuals to do it. I'm not as familiar with the lawyer side of it, with the judge side and the staff side, but I do know on medical side there is continuing medical credits, continuing your medical education, and the same thing also applies in a judge setting for a law setting. If this counts as continuing their law education.
I see. So these are like CE credits.
Yes.
Right?
Yes.
Okay. But it's optional, like you opt in, right?
Yes.
Okay, but it does count as that.
Yes.
So there's that incentive. That brought up one more question for. Oh, okay. So there, it's this misconceptions. How does MOUD work? All of these different things. I mean, what if they don't have MOUD in their area? But do we know anything about that? Because we know there are shortages.
Typically, I think that's a really good question, and I'm not sure about that, whether they actually have it in their court. From my understanding, it's a question of whether they allowed it or didn't allow it in their court, and the only reason I say that is because the majority of individuals who answered the survey and decided to take part was because they saw that it was MAT and they deemed that they were very knowledgeable about it. So either they were knowledgeable because they had already had experience with it in their courtroom or decided they didn't want it in their courtroom, or perhaps they were knowledgeable about it because they wanted it in their courtroom. I'm imagining it's one of those two avenues.
Got it. Okay. Thank you.
You're welcome.
Other comments, questions? Okay, well, seeing none, we're going to finish a little early, but that's okay. We can grab our lunch before the speaker. And there's also a student poster session at 12:15, so you can see some additional students' work. One of the things I like about all conferences, but this conference, the mentoring and role modeling that goes on. Dr. Atkins helping with the PhD students who did very well, by the way. Also role modeling, Michelle is in my undergraduate research methods class. And I talk about descriptive statistics, but here we've heard people actually use the term and talk about it. So it's a chain where we all learn, and so that's a good thing. These were three papers, three topics that I did not know much about, so I enjoyed hearing about each one and learning a little bit about each one. And so I congratulate you for your research.
Thank you so much.
And if there's nothing else, I think we'll close it up. And thank you again. And we'll see you probably later on.